Thank you so much for asking me to speak on this topic, which is neoadjuvant therapy in breast cancer. Is it an option or is it a necessity? So in the next 15 to 20 minutes, I'll try to see if I can save some time for you. This is what we will discuss, right? Now, let's start by asking the question, why and when did we really need to use neoadjuvant therapy at all? Because we've shifted so much to this endpoint called pathological complete response that we've actually forgotten where we actually started. Now, the most important reason to do neoadjuvant therapy is when you can't get to breast conservation surgery upfront, but you want to convert it, or if you've got somebody with an inoperable, locally advanced breast cancer, wherein you can't get around the tumor with negative margins. So in my opinion, that is the most important reason to do neoadjuvant therapy, to get to breast conservation surgery, cytoreduce, and then operate somebody who's got an inoperable, locally advanced disease. The second most important reason, I think, is to escalate therapy based on your surgical pathology. Now, that depends upon whether you got a pathological complete response or not. We'll dwell into that a little deeper as we go by. The next reason might be if you want to have lesser surgery. Now, I'm talking about sentinel lymph node biopsy after neoadjuvant therapy, though not standard everywhere, is creeping into the guidelines. Or maybe in the future, you may not need surgery at all if you have excellent, effective drugs there. Now, we kept on saying pathological complete response is a very important prognostic factor. So the question is, can you de-escalate therapy if you get pathological complete response? Again, we will look into that issue as we go by. Now, there's also some discussion in the panel on whether we should institute chemotherapy early. Now, if you start with neoadjuvant, you are actually mitigating that particular issue. The other question is what Professor Govind Babu was actually talking about. You want to in vivo see whether your tumor is a good tumor or a bad tumor. So you're using pathological complete response as a surrogate for event-free survival and overall survival. So these are the many reasons that I could think of as to why one should be thinking about using neoadjuvant therapy. But I think for everybody listening here, the very important point to keep in mind is remember that the benefits of this therapy are similar whether you did it neoadjuvant or adjuvant. And where do we get that evidence from? These are good old trials. We're talking about NSABP B18 and 27. Now, the cartoons on the left tell you about the trial randomizations, and the ones on the right is the 2008 update of these studies, which is showing you the Kaplan-Meier projections for disease-free survival on your right extreme and overall survival. Now, NSABP B18 tried to look at AC before surgery or after surgery, and you find that there's absolutely no difference in the disease-free survival or overall survival. Similarly, NSABP B27 looked at just AC as neoadjuvant, or AC and docetaxel as neoadjuvant, or only AC as neoadjuvant and then surgery and then docetaxel. Again, you see on the right side, the Kaplan-Meier curves are sitting exactly on top of each other. So the most important lesson to learn is that whether you're doing it as neoadjuvant or whether you're doing it as adjuvant, it doesn't matter as long as you're delivering all of your treatment. So this is very important to keep in mind when you're reading a trial. The second important point to keep in mind is that the longer you treat, the more drugs you use, the greater is the pathological complete response. And that is something that I have listed at the bottom of this slide. AC times 4 gives you a path response of pathological complete response of 13%. If you did all your chemotherapy upfront, you got a pathological complete response of 26%. And bang on AC times 4 gives you 13% path CR in the third arm also. Now, does it mean that doing neoadjuvant here and getting to a 26% will get your patient a greater chance of a cure? The answer is no, as long as you've delivered all your therapy for this particular patient. So remember, pathological complete response is not only a reflection of biology, it is also a reflection of how long you have treated and how many agents you have used before surgery for that particular patient. Now, this is again a very important principle. Now, as I started by saying, the most important reason for doing neoadjuvant therapy is to get to breast conservation surgery, or when you see a tumor like this, which is not very uncommon in the areas that all of us practice. So you can't get this patient to surgery. You might have a heroic surgeon who might do a huge chest wall resection and a graft, but I think that's not the way to go forward. Neoadjuvant is an absolute indication in both of these clinical situations. Now let's get to the most contentious issue here, which is escalation and de-escalation of therapy based on pathological complete responses. Now let's start by first defining what pathological complete response is. And the most accepted definition today is the absence of invasive tumor in the primary and in the lymph nodes. So that's the most accepted and the most tested definition of pathological complete response. Now, this was an FDA-led meta-analysis that was published many years ago, but I think it's a very, very useful meta-analysis, which clearly tells you the importance or the prognostic importance of achieving a pathological complete response. If you achieve a pathological complete response, your event-free survival and overall survival are better. Now, where did you get this? This is when you did an individual patient level analysis. Now, what does an individual patient level analysis mean? It means that irrespective of which arm of the trial you were in, if you got a pathological complete response, you are grouped together, right? It doesn't matter if you got HER2 positive disease, whether you achieved a PAT-CR with Herceptin or without Herceptin, you're grouped onto one side. And all patients, irrespective of whether they receive the anti-HER2 therapy, are grouped onto the other side. And then there's clear evidence that irrespective of what therapy you received, as long as you got a PAT-CR, your outcome was better compared to somebody who did not get a PAT-CR. But the story changes a little when you do what's referred to as a trial level analysis, right? A trial level analysis means you keep patients where they belong to. If you're in the standard arm, you remain in the standard arm. If you're in the test arm, you remain in the test arm. Now, this looks like a very complicated graph, but please stay on with me. I will take you through this. Now, the y-axis here shows the hazard ratio for event-free survival. The x-axis here is the odds ratio for getting to a pathological complete response. Now, let's think a bit logically, forget about all the circles here. As the odds of getting a PAT-CR increases, which means as you get to the right extreme of this graph, you should get to the bottom of the graph in terms of the hazard ratio. So if your pathological complete response was a great outcome marker, then all of these circles should actually be in this corner of this graph, which means the odds increase, the hazard ratio actually increases. But is that what you're seeing on this graph? No, you see that these circles are thrown all over the place, which means that even if the odds increase, your hazard ratio for EFS or OS is not getting better. So what does this mean? When you look at it from a trial level analysis, it is not a great marker to predict EFS and OS. Now, what's the point we are trying to make here? We still don't know what is the difference in pathological complete response that you need to achieve in order for that to translate into a better event-free survival and overall survival for the test arm. I hope you understood that, right? If you get two arms in a trial, you need to have an X difference in the pathological complete response. Now, we don't know what is that X, what is the delta there in order for that new treatment to lead to a better event-free survival and overall survival. And that is exactly what these two trials actually showed. Now, the one on the left, top left, is the Neosphere study. The one on the right top is the Neo-Alto study. Brilliant studies where pathological complete responses actually doubled. Okay, what would you expect? If you did that in the adjuvant setting, you should shoot there with an improvement in the event-free survival and overall survival. But did that happen? That did not happen in the ALTO trial, in spite of combination of anti-HER2 therapies giving you better pathological complete responses. In the affinity, the addition of pertuzumab to trastuzumab improved the distant disease-free survival by 0.9%, while in the neoadjuvant setting, the pathological complete response was actually double. Right? So this is exactly the problem when you use pathological complete response to make all your decisions when you're treating your patients, right? So this is an important point to keep in mind. The other important practical point is that a PCR does not guarantee cure. And if your patient achieves less than a PCR, that does not necessarily mean a poor outcome, because in spite of getting a pathological complete response, 10 to 15% patients can relapse. In spite of achieving less than a pathological complete response, 70% may not actually relapse. So please don't tell your next patient that you didn't achieve a path-CR, you are going to relapse. That patient might actually not relapse. And the converse, which is achieving a path-CR and not relapsing, may not always be true in many cases. So these are very important principles regarding pathological complete response that one should keep in mind. Now let's come back to where we started. We spoke about de-escalation and escalation. Now this is the algorithm for escalation of therapy in patients with triple negative cancer. Now, typically in patients with triple negative cancer, if you have a tumor that's more than 2 centimeters, or irrespective of the size, if you had a node positive tumor, then I think these patients should have dose-dense anthracycline taxane chemotherapy before surgery, all the therapy being delivered before surgery. If your patient gets a path-CR, observation and follow-up. If your patient doesn't get a pathological complete response, then 4.5 to 6 months of capecitabine has been shown to improve the overall survival. Where do you get that evidence from? It's from this CREATE-X study, where patients were selected based on whether they achieved a path-CR or not. If you did not achieve a path-CR, you were randomized to 4.5 to 6 months of capecitabine versus no therapy. And clearly, the study showed that there was an overall survival, which was driven predominantly by patients who were triple negative. Now, remember, this was not a pure TNBC study. It also had patients who were ER positive. Okay, so this is how we got to that algorithm, wherein all patients more than 2 centimeter or node positive, irrespective of the size of the primary, get all their neoadjuvant anthracycline taxane-based therapy before surgery, path-CR, no therapy further, no path-CR, then they get capecitabine for 4.5 to 6 months. What about escalating therapy for HER2 positive breast cancer? Again, the principle remains very same. 2 centimeter is the magic number. Again, here, if you've got somebody more than 2 centimeter, all your neoadjuvant therapy upfront, path-CR, then no further therapy. You just continue your trastuzumab only. If you didn't get a path-CR, then you jump to doing Kadcyla for these patients or TDM1. And where did we get that evidence from? It's from this Catherine study, which again randomized patients after 12 weeks of anti-HER2 therapy, which could be just trastuzumab or a combination of trastuzumab and pertuzumab. Look at whether your patient gets to a path-CR or not. If you got a path-CR, just continue your earlier plan. If you didn't get a path-CR, you escalate these patients to TDM1, and you get a lovely invasive disease-free survival difference of nearly 10%. And I think that is practice changing. But let's look at the run-of-the-mill patient that we will see, right? Now let's take a patient who comes to your outpatient, who's got a 3 centimeter tumor. The nodes are negative. That patient does not want breast conservation. And most importantly, that patient does not afford TDM1. your patient cannot afford TDM1. Should we definitely do neoadjuvant therapy in this patient? I'm talking about a 3 centimeter, no nodes, does not want breast conservation, cannot afford TDM1. So in this situation, is it wrong to go and operate upfront? I think the answer is no. It's perfectly all right to operate this patient upfront because this patient does not really fit into any of these criteria that we started with in order to get to neoadjuvant therapy. So remember that you might have a HER2 positive disease, but still there may be situations where neoadjuvant therapy is not a compulsion there. Now, this is not my slide. This is Dr. Eric Weiner's slide. And I love this slide because he clearly says, and I very much agree with that, is that we need to stop praying at the altar of pathological complete response, because all that it indicates is biology of your disease and the activity of a drug and nothing beyond that. Though that's very, very important, we should not be striving to achieve that in all our patients. If our patients get to that, great. If it's not, there are ways and means of improving the outcomes for those patients. So this was a lovely editorial that came up in the JCO a couple of years ago, titled The Perils of the Pathological Complete Response. So what does it really say? It tells you that it's a favorable prognostic factor for the individual. So if your patient gets a PAT-CR, there's a greater chance of a cure, not guarantee of a cure. We've now got 2 lovely studies which tell us that if you don't get to a PAT-CR and you escalate therapy, the outcome is likely to be better. What about de-escalation of therapy? Can you stop therapy or shorten therapy in patients who get to PAT-CR? I think we cannot do that as of now. That is not standard of care because we don't have level 1 evidence to back that practice. So if you didn't get to a PAT-CR, escalate. If you get to a PAT-CR, it doesn't matter. You still have to continue your therapy. Now, this will lead to rational design of clinical trials. There's a substantial body of trial level data that suggests that it is not a surrogate at the trial level. At the individual patient level, it's a super surrogate. But at the level of the trial, it becomes a poor, surrogate for outcome. Last couple of slides. What about downscaling your surgery at least to the axilla? This is part of the NCCN guideline. I have not updated the slide because it's no different this year, that there are centers now who have started doing sentinel lymph node biopsy after neoadjuvant therapy if they get a clinically negative axilla. But there are some problems associated with doing that. I don't want to get to elaborating that, but if you're somebody who believes in that, you've got nice data to support it, you should go ahead and do that. Now, this is something that was again discussed in the earlier panel, talking about early institution of therapy, especially for those rapidly multiplying cancers. We are talking about HER2 and triple negative cancers. Now, this is retrospective evidence of just over 600 patients. They looked at what's the outcome if you start adjuvant therapy within 30 days, 31 to 60, 61 to 90, and so on. It looks to be that if you start beyond 30 days, you seem to be making a compromise in terms of the overall survival. But this is retrospective data. You have to interpret it with a lot of caution, but this is the best data that we have. Now, the reason why I'm saying you have to interpret it with caution is look at what happens 31 to 60, 61 to 90, more than 90, the overall survival is no different. But if you just delay it from 30 to 31 days, you get a 15% drop in your overall survival. But that's a little bit of a brainer there, right? So how is this really happening? Delay, is it really, is it really the problem, or is there something else as far as this is concerned? But generally, all of us are taught to believe that early institution is likely to be the best way to go forward. So in my opinion, neoadjuvant therapy is a compulsion in 2 specific situations. One is when downstaging is required. BCS, extensive tumor, you can't operate upfront. Certainly neoadjuvant therapy is the way to go. Escalation of therapies in patients who don't get a PCR, if your patient has access to that escalation therapy, We are talking about capecitabine and TDM1. Capecitabine is a cheap drug. Everybody can access it. TDM1 is not cheap. So that comes with a little bit of a rider there. But these are two areas where I think neoadjuvant therapy is now a compulsion. Where is it optional? Lesser surgery. We are talking about sentinel lymph node post neoadjuvant. Doing neoadjuvant just for the sake of prognostic information, that's an optional issue. If you do not have access to the escalation options, it is again an optional therapy. Early institution of systemic therapy, we don't have super evidence to back that, but at least that's what we believe. And if you are doing it for the sake of that, again, that is optional. So my thought ultimately is that in every patient whom you see, you should set your goals very clearly. Why do I want to do neoadjuvant therapy in this patient? And then if you did therapy, that would give you much more meaningful outcomes rather than blindly saying it's TNBC. If you don't do neoadjuvant therapy, it's criminal. It's HER2 positive. Don't do neoadjuvant therapy, it's criminal. I think that's not the way to go to, because if you don't know what you're going to get and why you're going to get, this is what you will end up having. And that's not what we want our patients to end up with. Thank you so much for your patient hearing. And if